thank you for coming to this presentation on current best practices of tracheotomy care. My name is Libby Smith, and I'm the director of the University of Pittsburgh Voice Center. While we are all involved in these cases, I hope that in the next hour you'll pick up some tricks of the trade and, more importantly, have a deeper understanding and thought process as to why we do what we do and what we do for tracheotomized patients. First, to clear the air, tracheotomy versus tracheostomy. These terms are often used interchangeably. Tracheotomy is actually the act of just making a hole in the trachea, whereas tracheostomy is making that hole permanent with sutured skin flaps. Technically, we usually don't do a tracheostomy unless we create a Bjork flap or maturostoma in a morbidly obese patient. Regardless, the literature and in real life, we use these terms interchangeably, and I will likely also do so during this presentation. So I have no financial disclosures or conflicts of interest. I will be mentioning different name brand tracheostomy tubes, but I have no financial interest or relationships with any of them, nor am I promoting one over another. These are the sources utilized to create this presentation. So the objectives for the next hour are to understand the current best practices for tracheotomy tube care, to understand the evidence and, frankly, oftentimes the lack thereof of current best practices for tracheotomy care, and to critically think about how we care for these tracheotomized patients, including early and late complications. The first record of tracheotomy was in 2000 BC, noted in a sacred Hindu text. In 300 BC, Alexander the Great apparently punctured the trachea of a choking soldier, on purpose, I presume. Fast forward 800 years to 500 AD, when tracheotomy was described as a, quote, fantastic operation that should never be done. And then only after Chevalier Jackson published a refined version of tracheotomy in 1909 did it become a, quote, safe procedure. So presently, tracheotomy has become one of the most common surgeries performed for a variety of reasons and by several different medical services. So these patients are often the sickest of the sick. About 20% of patients who receive a tracheotomy die during that hospitalization. This should make us question as to why and who should undergo tracheotomy. Unfortunately, this is a topic that will have to be tackled another day, but I suggest you start mulling it over on your own. So, wow, there is a lot going on here. Lines, tubes. So trach tubes are often the last things we worry about and sometimes considered with the same intent as an IV line. But it is a lifeline for the patient. So did anyone notice that this trach tube is being pulled at a weird angle? Is this important to realize, especially if the patient has increased vent settings? Whose job is it to notice amidst the multitude of different things going on for this patient? So part of this common snare is driven by the fact that most practitioners don't feel super comfortable with caring and troubleshooting trach issues. Frankly, I'd submit that most physicians don't feel comfortable either. So this is driven by the fact that tracheostomy now is performed by several different services, including surgical and traditionally non-surgical fields of medicine. With the advent of percutaneous and tracheotomy, that has brought the ICU and critical care medicine physicians into the business of performing tracheotomy. So several challenges exist in the care of these complex patients, centered around the fact that no one really wants to take care of them long term, because trachs are nasty. So if care and eventually decannulation becomes challenging, or there's complications associated with the trach tube, who troubleshoots it? The physician who performed the trach in the first place? In reality, as we all know, it often is left to the otolaryngology service to take over in these circumstances, even if we weren't involved in the surgery or patient care up to that point. So whether we like it or not, we are the trach leaders, masters of the upper airway. So we have to take on that role. with that in mind, we will go through the best practices of tracheostomy care, what we know and what we don't know. In 2012, an interesting publication showed who does trachs, what bad things can happen, and to which patients. It included 8 academic institutions collecting data for 2 calendar years, totaling 1,175 trachs in total. Turns out, not surprisingly, that trachs are not immune to bad outcomes, and trachs are being done by several different services, as we already mentioned. Non-ENT performed trachs actually have a higher rate of later complications than those performed by the ENT service. So, in 2013, the Academy published a clinical consensus statement on tracheostomy care, created by experts in the field. From this, we glean what is most important for the care of these trach patients. Big picture concepts like earlier tracheotomy is better than later when it comes to damage to the larynx and trachea. There's a lot of different ways you can perform a trach: open, percutaneous, Bjork flaps, cartilage resection, vertical or horizontal incisions. Some place stay sutures around tracheal rings, but the vast majority of sutures don't, but rather almost everyone sutures the faceplate to the skin unless it's medically not advisable. It turns out, in looking at the data, that the suturing the faceplate is what reduces most accidental decannulation. So we're not going to go through all the nitty-gritty, but we'll try to hit the high points with some editorialization along the way. So first, there are so many different types of trach tubes, and we need to have a general basic working knowledge of all of them. So each hospital has certain trach tubes that they supply based upon decisions often made way above our level. So regardless, we need to understand what's good and not so good about which trach so that we can apply them to our specific patients. So education should start early. It needs to be involving the patient, family, caregivers. Like I said, it has to happen early, sometimes even before the tracheostomy is placed, but it also has to happen often, repeatedly, because trachs are not the first thing that people are usually thinking about until the day before or the day that they're being discharged to another facility. So when possible, it's always best to discharge a patient with an uncuffed tube, and they should always go home with a spare. So let's delve into some of the early complications. We'll look at how we can prevent these through best practices. So complications within the first week after a tracheostomy are uncommon, less than about 5%. So bleeding, mucus plugging, tracheitis, and accidental decannulation top the list. So after a tracheotomy, the natural humidification from breathing air through the nose is actually removed. So this results in a drying of the airway. And with that, you get crusts and eventually obstruction from those crusts. So humidification is actually the answer. And all trachs are messy right after insertion. There's lots and lots of mucus, and just everyone hates that part of it. But the trachea must become accustomed to having that piece of plastic in there and altered airflow and less humidity. So humidification actually facilitates restoration, or at least improvement, of the secretion mucociliary transport, which results in less crusting, less accumulation, and therefore less obstruction of the trachea. So humidification is provided through the ventilator tubing or via trach mask. If the patient is no longer on the ventilator, a trach mask is always preferred since it won't pull and tug on the trach tube itself. Chronic tracheotomized patients will become accustomed to a drier tracheal environment over time, but we still need to add the humidification. And so it's suggested to use nighttime humidification via trach mask, using heat moisture exchange devices, HMEs, during the day when able, and or adding nebulized saline throughout the day as needed. So along with humidification, suctioning in the early postoperative period is super critical when these secretions are most abundant. So this task usually falls to the nursing staff, but we're often asked as to how often and how far to suction. So frequency of suctioning really depends upon what's needed. No one likes the answer to that, but that's just actually how it is. So there's also no consensus on how far down you need to suction, just to the distal tip of the trach tube or deeper into the trachea. Most advocate just to the end of the trach tube because deeper suctioning can cause tracheal wall trauma. So tracheal wall trauma begets more secretions and bleeding, which begets more suctioning, which then that vicious cycle just starts brewing on itself. Stomas need to be kept clean and dry. So different trach tube faceplates are more or less irritating to the underlying skin, and some of the new ones purport themselves to be less irritating and with less wound breakdown. Regardless, someone still needs to be checking the skin for wound breakdown, which means peeking underneath the faceplate. So this patient here has a history of radiation for thyroid cancer, external beam radiation for thyroid cancer, and developed a pseudomonal and stomal infection that eventually became systemic, all because no one was checking underneath the stoma, even after she started developing some erythema that had migrated to her neck and chest. So she ended up doing well with systemic antibiotics, but truly earlier identification should have occurred. And it comes down to ownership of all aspects of trach management, and ultimately that falls to us. So trach changes are often viewed as, quote, routine, but the initial one is not, and is actually fraught with danger and should be considered as such. So it's recommended that the first trach change be done by the team who placed it. But as we all know, that's oftentimes in reality, what happens, and it defaults to us. So first, there should always be a reason to change the trach tube. The patient no longer needs mechanical ventilation, the upper airway edema that led to the tracheostomy has subsided, whatever it may be. In an open trach, the first trach change really should happen no earlier than 3 days after the surgery. And move that out to more like a week or so in a percutaneous tracheotomy, just because the tract isn't as well formed. I would say also that if you have a diabetic patient, maybe do that first trach change a little bit later so that the tract does have more time to form. The use of stay sutures in adults is not universal and has not actually been shown to prevent accidental decannulation, so it can be up to the discretion of the surgeon if they want to place or not. However, I know that my residents prefer having them because they're used to using them in the first trach change and they find it helpful, so you do it when possible. It's also recommended to have a smaller trach tube available emergently / in the room with you in case the one you want to place doesn't go in the way you think it should. And so you have a backup smaller one in case of emergency. You can use a flexible endoscope to confirm placement. That's not routinely done, but if there's any concern about placement, that's a surefire way to know that you're in the airway or not. It's also nice to use flexible endoscopy to not only make sure the tube's in place, but also that the tip of the tube is not abutting the tracheal wall. And in long-term trach patients, the question becomes, well, how often should we change the tubes? And again, there's no good answer to that, and so it's really up to your clinical judgment. So I'll tell you that plastic and silicone tubes do develop a biofilm, and that can lead to stoma, stomal tract, and tracheal wall irritation. They can also start to smell a little bit. So patients will sometimes describe the sequelae of this as pain or increased phlegm or secretions. And frankly, if they're a smoker, the tubes just get really nasty, so they probably need to be changed more often. Challenges can arise in the setting of an inadvertent accidental decannulation. So oftentimes little is known about the patient, like why was the trach there in the first place, and were there any issues in placing it in surgery? The question is, are there correct supplies at the bedside? So there always should be like a trach care emergency trach setup in the room. Using a flexible laryngoscope to help replace the trach tube is oftentimes really helpful, especially if there's challenging anatomy and it was a fresher trach. And as a last resort, if you're not able to get the trach back in safely, most patients can still be intubated from above. So this happens not infrequently where surprisingly a patient has an accidental decannulation, is actually doing fine breathing wise. Their oxygen saturates are fine. There's no, work of breathing. So then the question is, well, do they still need a trach tube? And depending upon the situation, that might be something to consider. Now, it's a little bit hard when you're coming in not knowing anything about the back history on the patient. So that's something to think about. So to this end, we had this happen several times recently. And so one of our residents developed a quality improvement project to help with this. So I mention it, and maybe it's something you want to think about at your institution. So above each tracheotomized patient in the hospital, there's an information sheet detailing who the surgeon is, why the trach was placed in the first place, what exact tube is in place, and then what are the goals for decannulation. And we're hoping that this will help in those scenarios. All right, so let's move on to late complications. Those occurring greater than a week after surgery. So the rate creeps up a little bit from 5.6% to 7.1%. The complications noted under the early complication list are still there, but now we've got some new ones. So tracheocutaneous fistulas are not serious, but rather a hassle for patients, and you have to do more laundry. Usually surgical closure is needed. Granulation tissue at the stoma and suprastomal area sitting on top of the trach tube within the tracheal lumen are actually super common. I think they happen more often than we know. We just know it when it's bothersome, but it's probably there a lot of the time. Stomal granulation tissue leads to more bleeding and more secretions and sometimes soreness. So suprastomal granulation tissue is usually not an issue until the patient is ready for capping trials or decannulation, at which point that granulation tissue can fall into the airway and partially or completely obstructing the tracheal lumen. So granulation tissue can also result from tracheal wall irritation from the trach tube tip or cuff, even when it's deflated. So the best answer to correct this type of granulation tissue is to transition to a cuffless tube. And so, or is there a different type of tube that you could use? Do you need to rotate it, prop it out, whatever it may be to bring that tube off of the tracheal wall? So probably one of the most common treatments for granulation tissue is silver nitrate cautery, and that works perfectly fine. It can hurt afterwards, but it's oftentimes used. I've started using more Decadron Otic drops, which I learned from our pediatric colleagues, primarily to the stoma for peristomal granulation tissue. I use like 5 to 10 drops a couple times a day for a couple weeks. And this oftentimes is great at melting away the granulation tissue. It's a little bit tough sometimes to get the drops there, so either the patients lay down and the caregiver holds up the flange and kind of drips it there, or they can use an angiocath. For suprastomal granulation tissue, that's a bit trickier because those steroid drops on the outside or putting through the tube itself just frankly won't get there. So if the patient can tolerate a short capping time, you can use oral nebulized steroid treatments. They work really well, but the patient does need to be able to cap at that time. Sometimes patients can also react more vigorously with different types of materials of the trach tubes themselves. So if you find that's someone who has a lot of peristomal granulation tissue, it's something to consider. So metal trachs often cause less granulation tissue, but attachment of a speaking valve and cost are sometimes prohibitive. So bleeding is a whole different ballgame. So most of the time, once you're past that early stage and you have more late bleeding, it could be just erosion into a thyroid vessel or anterior jugular vein. Can oftentimes require a trip back to the OR for control. Rarely a fistula develops between the innominate artery and the anterior tracheal wall. But this is why we check for a high grinding innominate. So one, we don't hit it during the surgery itself. Now, while erosion from the tube takes longer, it's equally catastrophic and looks just like this picture. So for these tracheonominant artery fistulas, there's oftentimes what we call a sentinel bleed, where you have bright red blood, smaller amount, starts, it stops, and then all of a sudden, whoosh, the floodgates open and you got blood everywhere. So if this happens, you have to hope that you're actually like right there when it does. You try to get a finger into the stoma to apply pressure on the artery. If you can't get your finger in there, which is really hard to do with a trach tube in place, you can, if there's an ET tube available, if you have a cuff on the tube, you can try to overinflate the cuff and pull up a little bit. If you have an ET tube at hand, you can put that in, overinflate the cuff, and again, push up while pushing down on the sternum. At this point, your thoracic surgery colleagues are your best friends, and hopefully they can save the patient. So now let's talk about the cuff. So when cuff pressure exceeds that of the capillary perfusion pressure, the mucosal nutrients are not delivered and the cartilage dies. And this results in either stenosis, seen here on the right, or malacia, seen in the middle. I guess this is stenosis also on the far left. So stenosis is the deposition of collagen from that injury, whereas malacia is not scarring, but rather the loss of structural integrity of the tracheal wall. So both are bad. Stenosis is often amenable to dilation and the same things we do for subglottic stenosis, whereas malacia doesn't tend to respond as well to dilation. It dilates it back up, but then it collapses back down, and therefore it oftentimes requires resection, stents, or T-tube placement. Tracheal stenosis occurs in about 1 to 8% of patients who have a cuff. Now, I work in a hospital with a level 1 burn center, and so this is germane maybe to me and for some of those of you who out there who actually also have the luxury of working with burn patients, is that the tracheal stenosis rate can increase nearly 20% to nearly 20% in burn patients. And so it's just something to be keenly aware of in these situations that you don't necessarily always think about. So when the cuff pressures are too high and you have that stenosis or malacia, it's happening in a far greater number of patients. All right, so how do we best monitor cuff pressure since that's so important? Well, I love this study. It's out of NYU and they're looking at digital manipulation of the cuff, like basically pressing on the pilot balloon versus doing manometry, versus actually I had another one where you just eyeballed it. And it turns out that we're really bad at like touching the little balloon and saying, oh, that's the right cuff pressure. Even though we do it all the time. And over a third of the patients were overinflated just by feeling that pilot line balloon. So with that in mind, what do we need to do? Obviously, eyeballing it isn't the best thing. So this is a Spanish study where they actually looked at checking the cuff pressures every 8 hours to reduce scarring. And they basically showed that it did. That if you constantly are reevaluating the cuff pressures, in this case every 8 hours, it reduced scarring and reduction of the endotracheal lumen. So this is time intensive and there needs to be people to do it, but the positive long-term effects are actually really notable and it should be something to be considered. So I know our hospital has adopted this policy where respiratory actually comes through every 8 hours and checks the cuff on every patient who has one. So a little bit about obesity and stenosis. So obesity is an epidemic in the United States. Unfortunately, but not surprising, obesity is significantly correlated with increased late postoperative complications, and in this case, airway stenosis. with a rate of nearly 10% for obese patients, and that's in opposite of the less than 1% in non-obese patients. So we know from subglottic work that diabetes and small vessel disease are often implicated in stenosis. For tracheotomized patients, this is likely no different. It's the same kind of concept behind it. And so that resilience to cuff pressures, even if appropriate, may not be as great. However, as an added confounding factor, obese patients tend to be intubated with larger tracheotomy tubes and also intubated with larger diameter ET tubes, but also tracheal tubes, as seen in this second graph. So this sets up these already at-risk poor protoplasm patients to have even more issues. So when obese patients are intubated with larger than a 7.5 ET tube, their rate of stenosis remained high at 1.9%, which is closer to their non-obese counterparts at 0.4%. But when you get up larger than that, your rates are increasing. So on a side note, in this study, they looked at, did the way the tracheotomy was performed matter? So open versus percutaneous tracheotomy. And when obesity was counted for, there was actually no difference in airway stenosis rates for the two techniques. So it's not the way you do the trach, it's the patient and the environment. All right, so these are examples of 3 different types of tubes. So on the very bottom, the Shiley standard tracheotomy tubes, the old standard Shileys. Above that, the new flex Shiley tubes, and then to the right, the Portex tubes. So this is a lot of numbers, and I wouldn't expect everyone to know the inner and outer diameters and lengths of every single tube that there is. So I don't know it either. So I actually have these charts up in my office for me to reference whenever I need to. So I'll use these to see if I need a tube to do X, Y, and Z, what tube option is going to be best to accommodate that. So whether it's placement of a speaking valve, capping, or decannulation. So one word of caution, when manufacturers will mention the inner cannula size, it's often reported when the inner cannula is actually not in, or the inner diameter is when the inner cannula is not in. So you need to see if that's the case and realize it, and then account for when their inner cannula is in for that inner diameter size. So even though the inner cannula does take up space, having that cannula in place is always recommended whenever clinically possible, since it is the safety valve in case of tube obstruction. So a little bit about our larger size patients and those with special considerations like tracheal stenosis or malacia, like we talked about. Specialty tubes with extended proximal and distal shafts are sometimes needed. So these tubes, or any tubes, depending upon what they're made of, can be less compliant or more compliant once they're in the patient. Some will soften once they're in. This can change the angle of the tube, which can frankly be favorable or unfavorable. So sometimes that's where, if you're having issues with granulation tissue, scoping through the trach tube when it's in and has been in for a while to see where it's sitting. So not surprisingly, studies looking at appropriately sized ET tubes based upon height have shown that taller folks have larger diameter tracheas, whereas vertically challenged patients, they can only accommodate smaller ET tubes. Well, this would actually be the same for tracheostomy tubes, so it's something to think about. So choosing the size of your tube solely on gender is actually not the whole story. It's more about how tall you are. So in this case, if you're 5'7", a 7.5 ET tube is reasonable. And you can look at the appropriate trach sizes to the far right that might also fit. So no one wants to have a tracheostomy tube. They're messy and they're a hassle. However, they can serve a life-saving purpose. So a non-tracheotomized patient There's improved comfort, improved perceived physical status, improved swallowing. So in order to achieve this, in order to achieve a safe decannulation, you must first know why the trach tube was placed in the first place. And most surgical situations are amenable to decannulation after there's been clinical improvement of the patient, for example, with prolonged intubation or prolonged mechanical ventilation. But if the tracheostomy tube was placed for an upper airway obstruction and none of that's been rectified, then decannulation obviously is not a good idea. So unfortunately, there is no universally accepted protocol to ensure successful and safe decannulation for all patients. So usually decannulation proceeds without issues, and we don't really think too much about it. But as leaders in trach care, what if it doesn't? Because that's going to fall on our lap. So this is actually what makes it hard and why we're entrusted with the troubleshooting skills to help these patients. The first step is to find out why the trach tube was placed in the first place. And this is often cumbersome, especially if the trach tube was placed by a different service, or frankly, better yet, at a different hospital. So it requires mining through the charts, but even more important, oftentimes just picking up the phone and having direct communication with the service who placed it, or the patient, or the care team prior to you, to basically gain a better understanding of how the patient got to where they are right now. In this day of electronic medical records, I think this is a lost skill, actually picking up the phone and talking to someone, but in these cases, it's really important sometimes. So there are positive and negative predictors for successful decannulation. There's pros and cons to everything in life. So predictors for failed decannulation are old age, obesity, poor neurologic status, sepsis, and copious secretions. While predictors for successful decannulation is everything opposite of that. So obviously no longer requiring mechanical ventilation and being able to protect your airway, being alert, having an effective cough, tolerating a speaking valve, managing secretions, meaning not needing to be suctioned more than, they say, 5 times a day, and obviously having a patent airway. While testing for cough effectiveness usually falls under the critical care umbrella, otolaryngologists, we probably rely more on looking at the larynx because that's what we do. So when decannulation is not moving forward as expected, laryngoscopy is often really helpful to figure out why. So here's a case that highlights what actually looking at the larynx can give you. So this is a 36-year-old woman who was found unresponsive after a purposeful drug overdose. She has diabetes, hep C, and borderline personality disorder. She was intubated for about a week before undergoing a tracheotomy, and once off the ventilator, the trach tube was downsized, usual protocol, but she was still unable to tolerate a speaking valve, and thus, smartly, a capping trial was not tried. So a flexible laryngoscopy showed fixed vocal folds in the midline position, and the patient was eventually determined to have grade 4 posterior glottic stenosis and deemed a poor candidate for glottic opening surgery, and thus remained tracheotomized. So looking at the larynx told us exactly why she can't tolerate a speaking valve, and exactly why a capping trial would be horrible, and why she can't be decannulated. So she now cares for her own trachs, and she's accepted it, and actually her voice is awesome, so she's happy. If the steps to decannulation are moving along, especially after laryngoscopy, then trach tube downsizing is recommended and commonly used. It's all about plumbing, shifting from initially caring about the air within the column, shown here in green, to a shifting importance on the airspace outside the trach tube within the trachea. And as we as we downsize, we increase that tracheoluminal air, making more available for the patient. So here's a case that highlights this concept of tube versus tracheal diameter. So this is a 28-year-old insulin-dependent type 1 brittle diabetic, super sweet lady who had a trach placed after a kidney pancreas transplant. So the trach tube was downsized, but she still couldn't tolerate a speaking valve. Her laryngeal examination was super normal vocal fold motion, widely patent subglottis. So kept thinking, well, there's got to be a reason why. And so she really wanted the trach tube removed now that she was feeling better. So she wanted to have decannulation. She was willing to see what needed to happen to do that. So in the office, I did a flexible bronchoscopy performed through the nose. The trach tube was removed, and it was determined that she had a very narrow caliber trachea. So she was only 5'2", brittle diabetic, and I wonder how much her diabetic status had an impact on that, and probably a lot. So she was just the victim of having too large a tube for her very small trachea, even though the tube itself was quite small. So this was her situation. Her air around the tube, even though the tube was the smallest one we have, was still too large to accommodate air that she could breathe. So collectively, she and I decided to decannulate her in the office, and then followed her up with airway observation for a couple days in the hospital, and she has been successfully decannulated and remains so. So despite these examples, the majority of patients probably undergo speaking valve and ultimately capping trials prior to decannulation. Capping trials are generally 12 to 48 hours with oxygen level monitoring. So after a successful capping trial, then you feel more confident for successful decannulation. The last thing you want to do is have to put the trach tube back in. So questions and debates continue on where these capping trials should be conducted, and basically always in the hospital, or sometimes can they happen at home. And I think it comes down to where you think it's safest and most reasonable. So I do have some very reliable patients who care for their trachs and have a very good knowledge of how to take care of their trachs, and they also have plentiful and willing support at home. I'll sometimes do a long capping trial in the order of weeks, with education on how and why to remove the cap if needed. All the other patients, probably the majority, complete capping trials in the hospital. However, I'll tell you that we've run into issues with these patients not qualifying for admission status and from their insurance companies, and so they're under OBS status, and they do get stuck with a larger portion of the medical bill, so we try to be understandable to that. So some have advocated just skipping the capping trial and moving straight to decannulation, and I think in certain circumstances this is absolutely reasonable. It really depends upon what got them to where they are right now. I think that laryngeal endoscopy and airway monitoring is still recommended in those cases, and oftentimes successful. So a little bit about fenestrated tubes. I know we all love them, but they can serve a purpose, and they do help oftentimes with speaking valve placement. However, the big downside, as we all know, is granulation tissue. So if you've been doing this long enough, you've seen the patient with a fenestrated tube and granulation tissue growing into, either running between the outer and inner cannulas, or basically obstructing the lumen within the inner cannula. So if you want to be safe and use a fenestrated tube, which there are certain circumstances where that probably is the best option, you need to verify that the fenestrations are within the tracheal lumen and not making contact with the tracheal wall at all. So this can be done by putting a flexible scope through the trach tube and looking up. And if you see black, that's airway, that's a good sign. If you see any pink, that's bad, that's mucosa from the tracheal wall, and so that tube will not work in that patient. So just so that you know, if you really feel strongly that a fenestrated trach is what they need, you can actually special order one and move the fenestration anywhere along the shaft that you need it. So the only downside to this is that customized trach tube now is a single cannula tube rather than double cannula. So here's an example of a failed speaking valve trial. Again, just another thing to show you what can go wrong. So this super nice 76-year-old woman had an amazingly bumpy medical course after having a mitral valve replacement surgery. She was noted in the operative record to have a, quote, high trach, purposely placed to avoid the sternotomy incision. So there is controversy about this, and it's usually not recommended, but regardless, that's what was done. But this is what can happen. So she came in, she was aphonic and obviously didn't tolerate the speaking valve and therefore capping. So a flexible laryngoscopy showed obstruction, complete obstruction at the subglottis, and so imaging was obtained, and this confirmed that. It also showed that the trach tube, as you can see in the two CT scans, was eroding into the lower part of the thyroid cartilage. So I don't think that anyone put a hole in the thyroid cartilage to put a tube there, but I think they did a crike. And I think just the pressure of the tube eroded north into the thyroid cartilage. So not only in this case will the tube itself block the airway, but you're also going to have enough inflammation from those cartilages that are not supposed to be touched by trach tubes to then create granulation tissue, and then in this case led to complete subglottic stenosis. So in her case, she deferred having a cricotracheal resection, which is what she needed, and mostly because of her age and multiple comorbidities. So she remained trach dependent and sadly completely nonverbal. So as we prepare for decannulation, let's review the checklist we've kind of gone through again. So the first one is the patient needs to be awake, obviously not requiring mechanical ventilation. Are whatever preceded them for getting the trach tube in the first place, has that resolved? And have they successfully been breathing on their own spontaneously? It's always best to make sure there's no upcoming surgeries in which intubation will be needed. No reason to decannulate someone and then intubate them a day later. Just hold off on the decannulation until after surgery. Have they tolerated a speaking valve trial and also potentially a capping trial, most notably without stridor? They need to do well. They need to be able to do their daily activities and maintain proper oxygenation. So depending upon the clinical situation, laryngeal evaluation, while the patient is awake, not asleep, and we're asked to check laryngeal function when patients are sedated in the ICU. It's not helpful. They need to be awake, not under sedation, not under GA, can be useful. So this is especially the case when the status of the larynx was important in determining if the patient needed a trach in the first place, or if their speaking valve trial or capping trials were not successful. Cough efficiency is often seen as a correlate for vocal fold motion, or at least vocal fold closure. So although trach tubes do not prevent aspiration, let me repeat that, do not prevent aspiration, and if anything, it might actually make it worse. They do allow you to suction out what has been aspirated if you're unable to cough it back up. So in those cases, a trach may need to stay. So while peak expiratory flow rates can be measured, I don't think practically they are oftentimes. The CCM folks will want a desired amount over 160 liters per minute, but I don't know if anyone does that in a clinical setting that often. So rather, most clinicians evaluate listening for an effective cough. So that cough should be crisp, not really muffled. Okay. In that crisp cough, you have vocal folds are contacting each other. Doesn't mean they're both moving, but they are contacting. When there's no effective crisp cough, they're not. The need for suctioning shows the ability, or frankly inability, to handle your own secretions, and that inability to manage secretions would actually be a reason to keep the trach tube in place. So unless that's changed, the trach tube probably needs to stay. So a little note on effective swallowing. I noted it here because it's on lists, but I think we should delve a little bit deeper into it. So think about it. So trach tubes themselves will tether the trachea to the neck, and this potentially will decrease the high laryngeal elevation that occurs during the act of swallowing. Now, also think about how many patients we see with dysphagia that don't have trach tubes. And no one is advocating that they should get trach tubes unless they're floridly drowning in their secretions. So if they're handling their secretions and not drowning in their secretions, then that swallow function, ability or not ability to do so, is not as important. But if they are drowning in secretions, then these aspirated contents as well as their own secretions can be suctioned through the trach tube and therefore maybe not be on the list for decannulation. So, I list this one so that it's noted, but also that realizing it's a much more nuanced item on this checklist. So this is my general algorithm, and it's kind of created from everything we just talked about. So remembering nothing's easy, and each patient's unique situation may alter your path through this. Maybe you'll have different things that you'll need to do along the way, but in general, this is about how it rolls. So if a patient has or is expected to have a normal upper airway, speaking valve is often placed. It's often done as an inpatient, usually fairly shortly after coming off of mechanical ventilation. Oftentimes before we even get to meet the patient, unless we're the performing service for the tracheotomy. So, however, if the patient has either an altered or possible poor upper airway, I like to look at the larynx before I put on a speaking valve because I want to make sure that that makes sense. All right, so if the speaking valve trial is successful, then I finger occlude the tube. I don't just go straight to cap, I finger occlude. And as I'm obstructing the tube, I hold it there for a little while, you can feel pressure backing up into it. If when I let go, there's not this rush of air that's built up, then I'm feeling a lot more confident about a capping trial. So in those cases, we'll put the cap, we'll kind of hang out, assess the patient, check the oxygen level, chit chat with the nurse, but always keeping an eye on the patient to make sure that they perceptually and number-wise are looking good. Even before a capping trial, we're always in communication with the nursing staff and the respiratory team, so everyone's on the same page and knows what's going on. So if that capping trial goes well, it's usually stayed on for like a day or two, again, depending upon your sense of confidence that decannulation is going to be successful. And so during that time, we're still monitoring the patient oxygen level and comfort with having the tube capped. In the hospital, it's a little bit harder to do, but you want the patient to be moving around and not just sedentary, because a sedentary airway size is maybe not as great as one that's needed if someone's moving around a lot. So that's something to think about also. The patients need to get up, walking around, that kind of thing. So let's take the circumstance that the finger occluding or capping trial do not go well. And in those cases, I think you need to think kind of outside the box. So this is where I'll consider bronchoscopy. I think also downsizing the trach tube is helpful. It really depends upon what size trach you have in the first place. There may not be a smaller size to go to, in which case bronchoscopy probably is your answer. And so you want to be looking for reasons why capping didn't work. So is there granulation tissue? Is there tracheal stenosis, tracheomalacia? What's going on? So if you figure all that out, let's say in this case they just need to be downsized, you redo the capping trial, and now they're decannulated. So in the case of decannulation failures, we talked about glottal and subglottal issues for obstruction in the cases we provided, right? So granulation tissue is super common, and like I said, it probably occurs far more often than we give it credit. And so I think you should actually just expect it to be there, and sometimes it can be so abundant that it's obstructive. You need to make sure that the trach tube is appropriately sized to allow enough air around the trach tube. Stenosis can occur from scarring resulting from death of the tracheal cartilage, from basically not allowing its nutrients to get there. Malacia can also happen, again, from that cuff pressure. So I want to discuss really briefly one other concept. I think it happens really commonly. It's not noticed right after decannulation, but a little bit of time out. And that's an A-frame deformity. So this is an example of again, super nice 67-year-old guy who had a trach placed after a really bumpy course after a myocardial infarction. After decannulation, he developed slowly in the next 4 weeks biphasic stridor. He could do his basic daily activities, but was short of breath going out to get the mail. Now, granted, he does live in Pittsburgh, so there's a lot of hills getting to that mailbox, but it was notable. So, he was wondering, is there something we can do about it? So, looking in the office through a transnasal flexible laryngoscopy, I did note that there was this small ring of subglottic stenosis right here, but also distal to that an A-frame deformity at his previous tracheotomy site. So this picture was obviously not taken in the office, but rather in the operating room when I dilated that subglottic stenosis, which was very effective, and he actually noticed that greatly. I dilated the tracheomalacia / A-frame deformity component. I didn't do anything, not unexpectedly, but he got enough improvement from treating the subglottic stenosis that he was able to pick up his mail without stridor. So think of it like this. The keystone of the trachea is violated by placement of that tracheotomy tube right through the anterior apex of the trachea. And if the trach tube is large enough that not only are you sometimes removing that cartilage, or just pressure of that tube up along the cartilage wall is going to exceed that of the capillary perfusion pressure. So this really can't be avoided. So the loss of that keystone really allows those two walls that were being held apart with a membranous component posteriorly, that no longer exists. So then they collapse in and you have your A-frame deformity. So sometimes you'll get scarring in that area, and then that kind of reconfigures that keystone effect. But if they don't and they get just malacia, that's when they'll have the A-frame deformity. So I think A-frame deformity is actually really common. I think oftentimes it's really mild and no one really notices, and so no treatment's needed. But when it's really severe and the patient has dyspnea associated with it, then treatment is needed. And treatment for this is challenging. So dilation, like I said, doesn't necessarily work well long term. So tracheal resection is the gold standard, but remember, a lot of these patients are just generally ill, and tracheal resection isn't necessarily the greatest idea. So you can do tracheal stents, you can put in a T-tube, or just a regular trach tube. So that's where those fall into. I'm not a huge fan of T-tubes because they're a little dangerous at times, but this is the perfect example of when they're really helpful for these patients. When dissolvable tracheal stents are fully realized, that's going to be a game changer for these patients. I wait for the day it's going to be awesome. All right, so in summary, we talked about early and late complications and troubleshooting issues with decannulation in the trach itself. We talked about best practices for trach care. We talked about education to the family and the patient is critical throughout this process, oftentimes even before the trach is done, but then educating them early and often and to everyone. So the more people feel comfortable with the trach, the better things are for everybody, not only them, but also you and your staff. If the patient cannot be decannulated while they're an inpatient, then sending the patient home with an uncuffed tube double cannula tube is often preferred. They also need to know, the family and caregivers need to know about a spare tube. They need to go home with one. They need to understand how to take care of the trach and how to troubleshoot issues if there's obstruction, i.e. suction through the inner cannula, take out the inner cannula, that type of thing. So thank you very much for your attention. I hope you learned maybe a trick or two along the way to help you in the care of your trach patients. Please feel free to email me with any questions and enjoy the rest of your day. Bye-bye.